शेयर स्क्रीन को ट्राई कर लो एक बार।
We are live now, doctor.
ओके।
Dr. Vishal, you are mute.
Okay. You can hear me now, right?
Yeah.
So, good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today. I am Dr. Vishal Agarwal, Scientific Committee Chairman, Rajasthan Ophthalmological Society, and it gives me immense pleasure to welcome you all for yet another masterclass of the online PG teaching program, Kaksha. Kaksha is conducted by ROS every month or every fortnightly, and it covers all the major topics of the PG current curriculum, which is being taught in colleges and in fellowship institutes. We bring the best of national and state faculty experts from time to time to share their knowledge and interact with you. The residents who have logged in today are also encouraged to put forward their doubts to the faculty in a fearless manner. They can raise their hand, they can type in the chat box, and every question will be answered promptly. As usual, there is a quiz kept at the end of the class, which is related to the content taught in the class, and lots of prizes to be won. So keep a strong vigil and stay glued to the Kaksha. Coming to this class, I have with us my very dear friend Mudit Tyagi from LV Prasad Eye Institute, Hyderabad, to teach us about the diagnosis, the management of the most common types of retinal infections seen and also very frequently missed in the OPD, and the common mistakes we make in treating them and diagnosing them, misdiagnosing them, because they might present in various forms masquerading with other diseases also. It's a very important topic in regards to retinal diagnosis. Just a brief about Dr. Tyagi. He did his residency training from BJ Medical College, Ahmedabad, and via fellowship from LB Prasad Eye Institute. And right now, at present, he's the consultant head of services at for VR diseases at LB Prasad Eye Institute, Hyderabad. His area of interest, apart from being a prolific VR surgeon, is uveitis and VKH, oculocephalus, ocular inflammation, and endoscopic retinal surgeries are his areas of interest. As we were discussing before, he is a keen innovator and he has developed and is this topic is being discussed in every forum these days. His innovation about fibrin glue in retinal surgeries, which has become very popular these days. Uh, he has various. He has yes. Sorry. He has numerous publications in peer-reviewed journals and has won various video awards in ASRS, Uretina, and is commonly invited faculty in all international national retinal conferences. I now welcome the ROS President Sanjeev Desai sir, President-elect Dr. Virendra Agarwal sir, and our dynamic secretary from Jodhpur, Dr. Ghulam Ali Kamla. Mudit, there are two residents on the hot seat, Sana and Pawan. Sana and Pawan, have you logged in?
Yes, sir.
They are all postgraduate students from various colleges. They are today's students are from JLN Medical College Ajmer, and you can interact with them informally and ask them questions if you want.
All right.
Over to you, Mudit. You can share your presentation and start.
All right. Yeah. So while the presentation is coming on, thank you so much, Dr. Vishal, for those kind words and that introduction, and to the Rajasthan Ophthalmic Society and everyone here for having me. Is my screen visible?
Yes, it is visible.
All right. So good evening, everyone. Thank you so much once again for that kind introduction and for having me here today evening. So when I was asked to discuss or talk about what do I want to share with residents and with fellows or whoever is joining, I thought I will talk about pattern recognition in different retinal infections. Now, the good thing about retinal infections is the fact that a lot of these are things which we can identify clinically. Misconception in uveitis is that you need to resort to a lot of tests, lot of lab investigations to arrive at a diagnosis, but that is not true. The good part about these retinal infections is that if you examine your patient nicely, if you are meticulous in your clinical evaluation, a lot of these diseases can be identified based on their clinical appearance. And as clinicians and ophthalmologists, it becomes important for all of us to get into the habit of identifying them, identifying the subtle clues which can help us in recognizing these diseases and arriving at a possible etiology just based on the clinical evaluation and clinical features. So I will be discussing some of these common retinal infections that we see in our clinic and how we can identify them based on their clinical appearance and with just some of the imaging modalities that we have at our disposal rather than resorting to multiple investigations. At any point of time, please feel free to stop me and ask any question if you have any doubt. I will be more than happy to take them at that point of time or maybe even at the end of our discussion. So now the first thought that we have to understand when we see any retinal infection is to understand what is the area of the eye that is being involved. Now the two most common manifestations are either it's a retinitis or it's a choroiditis. And how do you differentiate between both of them based on their clinical appearance? So look at the lesion carefully and try to trace the blood vessels over them and to understand their plane of the lesion. So retinitis lesions, as the name suggests, will be slightly superficial. And because they are superficial, they will be obscuring the underlying retinal vessel. So if you see a creamish, yellowish retinal lesion, which is slightly superficial and which is obscuring the retinal vessels, you are dealing with a retinitis. However, if the same lesion is slightly deeper, elevated, but you can see retinal vessels coursing over it, that means that the lesion is emanating from an area which is deeper to the retina. So that is from the choroid. So that's a choroidal lesion. So choroiditis essentially will have a lesion which is deeper and which will have blood vessels coursing over it as compared to retinitis, which is superficial and it will be obscuring the underlying blood vessel. So once that differentiation is clear, we can move ahead next to understand what are the different infections. So first and foremost, we have to learn to differentiate between these two entities, a retinitis lesion and a choroiditis lesion. So coming back again, look at these two lesions. The one over here where my pointer is there. If you can see, this is a deepish yellows oranges sort of a lesion over here. And you can see blood vessels moving over it. And that means that that's a choroidal lesion. It's a deeper lesion. So it's a choroiditis. Compare that to this yellowish lesion, which is superficial. And while you can see a blood vessel at the edge of the lesion, the underlying blood vessels, which are supposed to pass through this area, are all obscured. And therefore, this is essentially a retinitis lesion. And we'll come to what it is, but there's a very obvious clinical clue to what this lesion is. You see a pigmented scar over here, and you see a lesion at the edge of the scar. Remember, lesions with activation at the edge of scar are characteristic of ocular toxoplasma. This is a patient of a toxoplasma retinochoroiditis. So we'll come to that later. We'll come to toxoplasma later. But just as an initial entree or a starter, this is how toxoplasmosis retinitis lesions are with a scar which is there at the edge of the lesion. So you see a scar and a retinitis lesion at its edge. Think of ocular toxoplasma. Now, how else can you identify or differentiate between a retinitis or a choroiditis or a scleritis based on an FFA and clinical appearance? And this is a very important pearl which has helped me a lot in a lot of our disease dilemmas. And this is courtesy my teacher and mentor, Dr. Avinash Patange, who has been one of the people who has taught me a lot. Most of what, to be honest, that I know in retinal infections is thanks to the teaching of three individuals, and I believe it's my duty to acknowledge them. Dr. Rajiv Reddy, who has been my teacher and mentor in LVPI, Dr. Annie Mathai, and Dr. Avinash Patange. Anyways, so coming back to the clinical point, look whenever you get an FFA done at 2 points. Number one, the intensity of early fluorescence, and then the pattern of early hyperfluorescence. So early hypofluorescence intensity is maximum in retinitis, and I'll show you the example, followed by choroiditis and then scleritis. And pattern of early hyperfluorescence is perilesional, that is around the lesion in retinitis, intralesional in choroiditis, and pinpoint in scleritis. And let me show you the examples. So there are three lesions over here, one on top of the other. Now, if you see the one on top, there is a lesion over here. You get an FFA done, and what you see is, look at the hypo. Look at the pattern of early hypofluorescence. So this is the maximum over here. In this, the pattern of early hypo as compared to the one in middle and as compared to the third one. So pattern of early hypofluorescence is maximum in retinitis. And now look at the pattern of the hyperfluorescence. So see the hyperfluorescence over here. Look at this. There is a perilesional hyperfluorescence in this image as compared to intralesional over here. And the third lesion has got pinpoint leakages. So when you see pinpoint leakages, think of posterior scleritis. The other differential for multiple pinpoint leakages are a VKH or a Vokoyanagi-Harada disease and sympathetic ophthalmia. But those will not present with elevated lesions over here. So you see a nodular elevated lesion, you see pinpoint leakages, you get an ultrasound B scan done and you see this characteristic subtenon fluid, which we call as a T sign. Your diagnosis is clean, you are dealing with a posterior scleritis. You see a yellowish lesion which is slightly deeper, blood vessel coursing over it, shows an early hypo with diffuse hyperfluorescence. Subsequently, you are dealing with a choroiditis. You see a yellowish lesion which is early intense hypofluorescence with a perilesional hyperfluorescence, and you know you are dealing with a retinitis. So these three patterns help us in differentiating the type of the lesion that we are dealing with, whether it's involving the retina or the choroid or the sclera. So another patient, if you look at it, had these small two yellowish lesions. This was a seropositive patient incidentally. So HIV positive patient comes to you with these small lesions over here. And then when we did an FFA, what we found was an intense early hypo with a perilesional hyperfluorescence. And you do an OCT which shows you a full thickness involvement over here, small amount of fluid, occasional cells. This was a patient again of toxoplasma in a patient who was HIV positive. But the point is that your FFA and your clinical diagnosis in itself is able to tell you that you are dealing with a retinitis lesion over here in this eye. Moving on to some more clinical clues, some common infections that we see are number one, tuberculosis. So how do you look at clinical signs which can help predict ocular tuberculosis? Number one, do a clinical examination, and remember the hallmark of a good clinician is how meticulous you are in doing a good clinical examination. Do not resort directly to investigations or to lab tests. As physicians, as ophthalmologists, as clinicians, it's our duty to do a good clinical evaluation and look at subtle clinical clues. So if you see broad-based synechia, hypopyon, a clue to the fact that this may possibly be tuberculosis. But when you look inside the eye, you see these areas of confluent vasculitis, and more important than that is this, a subvascular pigmentation. A subvascular pigmentation is a very important clue to a possible ocular tuberculosis. And obviously disc edema sometimes is also one of the manifestations. But the most important sign which I want you to take back is a subvascular pigmentation in an area of vasculitis. That is a very characteristic feature of ocular tuberculosis. Retinitis overlying a blood vessel. Again, a clue to ocular tuberculosis. So you see your patient carefully, you'll see a blood vessel, and on top of it, you'll see an area of retinitis. Again, a clue to an ocular TB retinitis. The third most common pattern that we see is a serpiginous-like choroiditis. These are usually unilateral, will be having a peripapillary sparing. So you see a lesion which is not involving the disc area, but a choroiditis lesion. If you do an autofluorescence, sometimes you may find this hyperautofluorescent ring also. You may not even find it. But the point is, if you see a choroidal lesion, which may be placoid or which may be spreading in a serpiginous-like manner, not involving the disc, that again is a pattern of serpiginous-like choroiditis, which is presumed to be tubercular in origin. These are patients who will need ATT. Moving on to the other most common retinitis that we see in our clinic, that is toxoplasmosis. Toxoplasmosis in most cases presents as a unifocal retinitis. So the most common cause of a unifocal necrotizing retinitis is ocular toxoplasmosis. Now, why is it important for us to identify these diseases? The reason is that the most important part in treating retinal infections is identifying the disease. The treatment is actually very simple. The most important part is identifying. If you know you are dealing with toxo, you start your patient on Bactrim DS or anti-toxoplasma regimen. If you know you are dealing with CMV retinitis, you start your patient on ganciclovir or valganciclovir or whatever you have at your disposal. So we know what are the appropriate antimicrobials for those particular infections. The clue or the importance lies in, first of all, identifying them. Once the identification is done, the treatment is simple. So look at this, a unifocal retinitis, most common cause is toxoplasma. Can happen in immunocompetent as well as immunocompromised host. Frequent involvement of macula. There is no consistent direction of spread. There will often be an associated intense inflammatory response in vitreous. So, and arterial plaques and sheathing, then I'll come to that. So if you see a dense vitritis, so remember again, the next clinical clue is dense vitritis. If you see dense vitritis, sorry, the two most common causes of dense vitritis are toxoplasma and acute retinal necrosis. So if you see dense vitritis and through that dense vitritis, when you're doing your evaluation, you can see a unifocal lesion at the posterior pole, what we used to call frog in a headlight sort of an appearance. That sort of a lesion, if you see, you are dealing with toxoplasma. If you see lesions in the periphery, then you are dealing with an acute retinal necrosis. So headlight and fog appearance, sort of a thing which has been described clinically. If you see that, so dense vitritis and one small solitary yellow lesion shining through, toxoplasma, dense vitritis lesions in the periphery which were confluent, probably acute retinal necrosis. So see that. Now the other clinical clue which can be very important is absence of vitritis. Even that is a very important clinical clue. So if you see a patient with a very large retinitis lesion, but you do not see a commiserate vitritis, that is a clue to the fact that you may have a patient who is immunocompromised, because now they are not able to launch an immune response to the infection. So if you see a dense retinitis or an intense retinitis all around, but you do not see vitritis, it's important for you then to investigate your patient for HIV or any other cause of immunosuppression. So these are clinical clues which help you in deciding the direction of your treatment. So you see a unifocal retinitis, your diagnosis becomes nearly clinched up. It's a clinical diagnosis, toxoplasma. You see retinitis in the periphery, probably acute retinal necrosis. You do not see vitritis, probably you are dealing with an HIV positive patient. So remember, the other point to remember is that if there is a scar, usually the toxoplasma retinitis occurs adjacent to a healed scar. So you see a scar and you see an adjacent retinitis lesion, again your diagnosis is nearly confirmed. You are dealing with toxoplasma. So another one of our patients, this was a patient who came to our clinic. You can see one scar over here, one small scar along the superior arcade, one scar in the temporal periphery beyond the macula, and then you see one retinitis lesion over here. This again is a patient of ocular toxoplasma, started on bacterium DS, patient did well. But the point to remember is another clue. Look at the pattern of reactivation. So if you see reactivation or a retinitis adjacent to the scar, that is clue to toxoplasma, like what I've said at least 10 times in the last 5 minutes. However, if you see reactivation within the scar, that is a clue to TB. So tuberculous retinitis reinfections occur within the scar. Toxoplasma reinfections occur adjacent to the scar. So look at the pattern of reinfection, and that again will help you in understanding the etiology of the disease you are talking about. So reactivation from center of a scar, TB. Reactivation from edge of the scar, toxoplasma. Now moving forward, even an OCT through that lesion can help us in understanding. And there was a brilliant paper by this group from Dr. Alessandro Invernizzi and our good friend of mine, Anirudh Agarwal, where they essentially looked at the different OCT features to help you differentiate between a toxo versus a viral retinitis, and a full thickness retinitis with choroidal involvement with increased thickness of choroid underlying it is a clue to toxo. Another point which will help you in differentiating between that from a viral retinitis is the fact that in viral retinitis, there is intraretinal edema involving outer nuclear layers, and there may be hyperreflective vertical strips in the outer nuclear layer. So if you see these, think of the fact that you are dealing with a viral retinitis. And let me show you one more clinical clue which can help you in diagnosing toxoplasma. This is something which we have recently started noticing, and we have actually collected data and sent it for publication, which is what I'll show you. So if you see hyaloid getting adherent, see this OCT. What you see the full thickness retinitis, you see a small hemorrhage, but you see hyaloid getting adherent at the edge of this retinitis lesion. Hyaloid getting adherent is a very important clue to differentiate between toxoplasma and viral retinitis. There is a message in the chat box, which is how to see activation. So we will come to that, how to see activation, or in fact, I can probably just go back to one slide and show you, or I'll come to that, how to see activation. So if you see hyaloid getting adherent to the lesion, that's a clue to toxoplasma. In viral retinitis, hyaloid does not usually get adherent. You can see it candida, you can see it endogenous end off, because what happens is that the amount of fibrin and inflammation is more. But if you have to differentiate between viral and toxo, get an OCT done through the lesion, hyaloid getting adherent is a very strong clue towards this being toxoplasma. Again, one more lesion where you can see this hyaloid getting densely adherent over here. This is what I'm talking about. So this was a patient of toxoplasmosis. We started treating this patient with Bactrim DS, and see, you can now directly assess the fact that the lesion has started regressing. So there was a question in the chat box about how to see activation. The signs of activation are: number one, a retinitis lesion with ill-defined yellowish margins. Now see, as the lesion starts healing, you start seeing the margins are becoming more and more well-defined, and the retinitis is regressing. And now see over here, the complete retinitis has gone away. So the question in chat box by Manisha was, how do you see activation? Signs of activity are yellowish retinitis lesions with ill-defined fluffy margins. When the margins start becoming more well-defined or pigmented, those are signs of clinical resolution. So you see these lesions regressing and completely going away over here. So what we did with this idea, we went back actually and took out all the OCTs of the toxoplasma patients that we had. And we found that of the 97 eyes of toxoplasma, we found this hyaloid adherent in 70 eyes, which is close to 72% of eyes where we found the hyaloid to be adherent in this over toxoplasma as compared to viral retinitis lesions. So let me show you one more case where how this becomes important. So this was a lady who had a sudden decrease in vision since 20 days, was seen elsewhere, diagnosed as CMV retinitis because this lady is HIV positive, and was given intravitreal ganciclovir twice before the patient came to us. But you see this lesion is still persisting over here, even in spite of 2 injections of ganciclovir. Now we did an OCT, and again see this. This is what I was talking about. You can see hyaloid adherent over here. You see a full thickness retinitis, and you see a bit of a choroidal involvement. Choroidal involvement, full thickness retinitis, hyaloid adherent to the lesion. Put all of those 3 clues together and your diagnosis becomes clear. This was not a CMV retinitis. This was a patient of ocular toxoplasmosis. A vitreous biopsy was done. We gave the patient intravitreal clindamycin, started this patient on Bactrim DS, stopped acyclovir, and look at what's happening. Even though that PCR was negative for toxo, but we started the patient on Bactrim DS and intravitreal clindamycin, and look at how the lesion starts regressing. The complete lesion goes away, and you can still see this hyaloid adherent, but the lesion is completely regressed. So based on clinical clues, in spite of your PCR being negative, you have clinical clues. And remember, PCR positivity for infections is only 60 to 70%. So I'm sorry, somebody said something.
No, you can continue.
All right. So in spite of that, just based on your clinical examination, you see a patient who was a seropositive, was not responding to ganciclovir, had got all clinical clues which were coming together in a puzzle, which were pointing towards this being toxoplasma, treated with Bactrim DS, and the lesion completely regressed. The patient visual acuity finally was 20/30. Now moving on to viral infections. We have just discussed about toxoplasma. So now coming to CMV retinitis. Now you see CMV retinitis in hosts which are immunosuppressed. Now remember, cytomegalovirus is ubiquitous. It may be present in all of us, but it starts manifesting. It's an opportunistic infection. It starts manifesting when you or your patient is immunosuppressed. So remember, not only HIV, you may see CMV retinitis in patients who are severely immunosuppressed for one reason or the other, which may be post-transplant patients, patients on long-term immunosuppression. We had a patient who had a granulomatous meningitis, was on rituximab, methotrexate, and mycophenolate for their systemic disease, ended up developing CMV retinitis. though the most common presentation of CMV is in HIV positive patients. But how does it appear clinically? You will see areas of retinitis and you will see multiple hemorrhages. So hemorrhages, areas of retinitis, granular retinitis, again, sometimes arterial sheathing. When you see this pattern, think of CMV retinitis. Now, what you also need to remember is, again, like I said, patient with CMV retinitis will not have a significant vitritis. Reason being that your patient is not immunocompetent enough to mount an immune response. So when you see minimal AC reaction, minimal vitritis, but you see multiple areas of retinitis, clue to the fact that you are dealing with an immunosuppressed host. And if you see multiple hemorrhages, clue to the fact that you are dealing with a retinitis secondary to cytomegalovirus infection. So CMV has got some of its own characteristic patterns. You can see this, what has been described as a tomato ketchup sort of an appearance. You see intense retinitis with extensive hemorrhages. You may also see a characteristic pattern which is called a frosted branch angiitis, which is basically vasculitis with intense perivascular exudation. So frosted branch angiitis is again a pattern seen in CMV retinitis. So extensive hemorrhages and retinitis, granular sort of an appearance, which is the fulminant form. Remember now, in a fulminant form, the loss of vision occurs because of the macular involvement. You may also have a granular or an indolent form. You see this retinitis over here. And these are patients whom you need to monitor regularly, because what will happen is that these are the areas which undergo necrosis. And these are patients who are predisposed to developing a subsequent retinal detachment through the area of necrosis. So when you see a patient with granular indolent form, even when the lesions heal, it becomes important for us to follow them up, because they are at a risk of retinal detachment. So the most common cause of loss of vision in these eyes subsequently is due to detachments which can occur because of multiple breaks that happen in the areas of necrosis that occurs once this retinitis heals. And like we discussed, this perivascular form, or what we call the frosted branch angiitis, this is what I'm talking about. You see vasculitis with intense perivascular exudation. But remember, frosted branch angiitis can also be seen idiopathically in Behçet's, in blood dyscrasias in SLE. So when you see a patient with frosted branch angiitis, and this was one patient who had got frosted branch angiitis in a patient of SLE. So you see this intense perivascular exudation and multiple hemorrhages. So this patient, when we investigated, we found him to be, this was a lady, I apologize, was found to be positive for SLE. So remember the differentials for a frosted branch appearance: idiopathic Behçet sarcoidosis, lymphomas and leukemia. So a very important simple test can be a peripheral smear. So get a complete blood picture and a peripheral smear in all of these patients where you see a frosted branch angiitis. And of course, HIV, what we have discussed. Moving on to one more disease which is becoming more and more common in our clinics, and that is syphilis. Now, syphilis is a great masquerade. It can present in any form that you can envision. And therefore, it becomes important for us to test for syphilis in any case of retinal infection. In fact, in our clinic, it's a rule. Every patient who walks in is investigated for syphilis, irrespective of their etiology. And the good part about syphilis is that it's a disease which responds very well to treatment. The challenge is to identify it. So let me show you some clinical patterns which will help you in identifying these diseases. So syphilis can occur in immunocompromised or immunocompetent hosts. We'll have posterior placoid retinitis, and I'll show you what. Sometimes it can have the superficial multiple yellowish infiltrates. So this is a patient who has this placoid sort of a chororetinitis. Now, if you look carefully, you will see a placoid chororetinitis. You will see more intense infiltration at the edge of the retinitis. So a placoid retinitis with more intense infiltration at the edge, you are dealing with ocular syphilis. Another one of our patient, if you look carefully, you may not see much in this eye, except for a very careful evaluation may show some changes here. But when you do an autofluorescence, see, this is what we note. And that's why autofluorescence can be a very valuable clue. So get an autofluorescence done for these eyes. You see this area of hyper autofluorescence. This is the area of involvement. Do an OCT, and this again is a very characteristic pattern, this RP nodularity. So when you see RP nodularity, this placoid retinitis and these changes in autofluorescence, this was a patient which we saw in clinic just a month and a half back. And luckily, and I was very happy, my fellow saw this patient, saw this, and then saw this RP nodularity, and he called me up and said, I think I'm dealing with a case of syphilis. We got this patient tested for TPHA. TPHA and VDRL both came positive. So this was a patient of syphilis. Now, one point which I want all of you to take back is what is the test that we do for syphilis? Tests are divided into two, treponemal and non-treponemal. The treponemal tests are TPHA and FTA-ABS, and non-treponemal ones which we commonly do are RPR or VDRL. Remember, the non-treponemal ones have only got a sensitivity of 70 to 80%, whereas the treponemal ones have got sensitivity of more than 90%. So ideally get a TPHA done for all your patients to screen them. It's not a costly test. It costs only around 400-500 rupees in most clinics or labs. So get a TPHA done for every patient. Use VDRL titers to monitor the response to treatment. So a 4-fold reduction in VDRL titers is a clue to resolution of syphilis along with a clinical cure. And the treatment is pretty simple. IV penicillin, crystalline IV penicillin, 12 to 14 million units for 14 days is the treatment prescribed for ocular syphilis. Syphilis has to be treated like neurosyphilis according to CDC guidelines. If you do not have access to penicillin, or if your patient is not tolerant to penicillin, has a past history of anaphylaxis, then ceftriaxone. If IV ceftriaxone is also not available, then oral doxycycline 100 milligrams BD for 28 days is the third line of treatment. But the first line of treatment is IV penicillin. You also obviously need to screen the partners of such patients. So like I said, RP nodularity is a characteristic clue and a photoreceptor damage in these eyes to acute syphilitic placoid chororetinitis, which is one of the characteristic patterns of syphilis. So this is what we are talking about, changes in RP and some photoreceptor damage. The other clue to syphilis are these small yellowish miliary lesions. So if you see a small multiple miliary lesions, you do an OCT through them, you find a full thickness retinal involvement. That again is a clue to syphilis. So these are clues to syphilis, a placoid chororetinitis, multiple small miliary lesions. So let me show you how these clues can help us. So this is one more case. This was a patient who was seen somewhere else, was thought of as an optic neuritis. The time of presentation, the patient vision was 2014 the right eye, 2016 the left eye. He was thought of as optic neuritis, given IVMP, the vision did not improve, was subsequently given posterior subtenon in the left eye, and this is what happened 1 month after. This is the right eye and this is the left eye, and left eye is no PL. So one more point which I want everybody to take back, please, is no depot steroids in retinal infections unless you are sure of that infection you are dealing with. No steroids without the cover of an appropriate antimicrobial. So depot steroids, Ozudex, posterior subtenon, intravitreal triamcinolone, absolute no in retinal infections. So no depot steroids, please. That is the second take-home message which I want all of you to take back. So this patient was given posterior subtenon and left eye became no PL. And when we saw these multiple miliary lesions. We got an OCT done. It was full thickness retinitis. We got the patient tested for TPHA. TPHA came positive. Patient was started on penicillin. This is what we're talking of in terms of the OCT findings. See this full thickness retinitis that we talked about. 1 week after starting penicillin, the visual acuity in the right eye improved from counting fingers close to face to 20/100. Final visual acuity after 2 weeks, 20/40 in the right eye. Left eye is no PL. We can't do anything about it. But fortunately, we were able to save one eye and the patient maintains a vision of 20/40 till date. So pattern recognition in syphilis, a placoid chororetinitis number 1. A ground glass retinitis with a central clearing. Number 2, multiple small miliary lesions. Number 3, you see these, think of syphilis. Posterior retinitis, another common presentation that can happen. You can see these multiple areas of retinitis, few hemorrhages, hard exudates. Happens in immunocompetent, frequently involves macular disc. And that's why it becomes important for us to take a history. Your patients may give a history of an episode of fever or typhoid or exposure to rats or even feline species. So you may be dealing with Bartonella. So take proper history of any history of fever which has happened earlier, and you may be dealing with a posterior retinitis. Moving on to one more common pattern of retinal infection called acute retinal necrosis. Now, acute retinal necrosis, we discussed, you see intense vitritis, and unlike toxo, where you were supposed to see a lesion usually in the posterior pole, if you see lesion in the periphery, confluent, think of ARN or acute retinal necrosis. So can happen in immunocompetent as well as immunocompromised host, predominantly located in the peripheral retina, has got a pattern of a circumferential spread. So this is again one patient of ARN. You can see this extensive areas of retinitis in this eye with peripheral involvement, which is confluent. So this is a classic acute retinal necrosis. Progressive outer retinal necrosis occurs in severely immunosuppressed hosts, predominantly in HIV positive patient. You will see retinitis and you will see this perivascular sparing over here. So when you see retinitis with this perivascular sparing, this broken mud sort of an appearance, think of progressive outer retinal necrosis. Moving on to one more disease, which is endogenous endophthalmitis. Some of the most common causes for endogenous endophthalmitis are fungi, most common being Candida. And if you see a patient who has got any history of systemic infection, history of any intervention done, this was actually a patient who had undergone a hysterectomy and came back 1 month after hysterectomy with this yellowish sort of a lesion at the posterior pole. Think of it. Now, Candida and Aspergillus, two most common causes of endogenous endophthalmitis, can be identified or differentiated on the basis of clinical appearance. Aspergillosis is more fulminant, predominantly confined to the subretinal space, and I'll show you some examples. So another paper by the same group in Elizondo and Vernizzi, where they describe the OCT features of Candida. And this is a very characteristic sign which is called the rain cloud appearance. So it comes from choroid bursts through to the subretinal space, through the retina into the vitreous space, and then you can see this extruding into the vitreous. This is called the rain cloud appearance. And this is pretty characteristic of Candida endophthalmitis. Compared to that, Aspergillus has got, like I said, a more subretinal extensive involvement. So you see extensive subretinal involvement in a lesion that is clue to Aspergillus, whereas a rain cloud appearance is characteristic of Candida. So now let me show you one more case to illustrate what we're talking about. So this was another patient who came to us with decreased vision in both eyes, right eye as well as left eye. And if you see this left eye, you can see vitritis and you can see this fluffy sort of a lesion protruding into the vitreous. We got an OCT done through this eye. You can see this lesion in the subretinal space about to intrude into the vitreous. And when we did the lesion through the other eye, you can see it's already protruding into the vitreous, that rain cloud appearance that we discussed about. Did a vitrectomy for this patient, gave this patient amphotericin B, and this patient responded well to treatment. So this, when you see this sort of an appearance, think of endogenous endophthalmitis and a possible Candida as an etiology. Aspergillus, like I said, will have a more diffuse subretinal spread. You may also see hemorrhages because it causes also an associated hemorrhagic vasculitis. One more differential, if you see multiple crops of retinitis in one eye, think of DUSN, again, diffuse unilateral subacute neuroretinitis. And the last differential, till now we have discussed infections. One more clue to retinitis is Behçet's disease. So if you see a patient who gives history of oral or genital ulcers, you see retinitis lesions, you see peripheral vasculitis, think of Behçet's also as one of your differentials, though it's a non-infective retinitis. So probably the only non-infective etiology which we are discussing today. So we have already discussed this case in terms of patterns of toxo. And let me show you now that we have discussed some of these infections. I will take a break now of 2 minutes and invite any questions for anyone. Any questions on the chat box or any comments from any of our participants? Dr. Vishal, anyone, any thoughts?
So the gist of what you have said is that what has been taught is that any vitritis or any infection, it's we are very happy to give overload the patient with steroids, and what you're saying is that should be done with a lot of caution because it can exaggerate the situation, specifically in cases of syphilis, and that should not be done without all the tests being positive or negative, right?
Any retinal infection, steroids should not be given without an appropriate antimicrobial cover.
Yes.
And no,
And in that also, the depot steroids should be avoided because it's very difficult to remove them once you have injected.
exactly. Yes. That is where it is like very good point, Dr. Vishal. The point is that if you have given a patient systemic oral steroids, you can stop at any point of time. A depot steroid is an arrow which has been shot, which is irretrievable. The only way ahead is you go inside the eye, remove the Ozodex implant, or do something like that. Otherwise, it's like a disaster if you're given a depot steroid. Not only for syphilis, we have seen patients of toxoplasma who have come back with worsening and with atypical presentations, viral infections which have worsened very badly, and eyes have gone into phthisis because they were given a steroid injection without understanding the underlying etiology. Somebody has a question in the chat box. I believe Dr. Manisha Singh has a chat box question: how to differentiate DUSN picture with syphilis? Now, DUSN is unilateral, number one. Number two, if you remember the slides which I had shown in terms of the pattern recognition of syphilis is totally different from what you see in DUSN. So let me show you the pattern of syphilis once again. Yeah. So this is it. So you can see a placoid chororetinitis. You don't see that in DUSN. You don't see miliary lesions. You don't see ground glass retinitis. And DUSN is usually unilateral. The other point is, if you remember, I told you every patient who comes to our clinic is investigated for syphilis because it is such a great masquerade. So you get a TPHA done. If it is positive, you are anyways probably dealing with syphilis rather than anything else. Dr. Alpesh has given drug of choice for toxobactrim DS, azithromycin, and yeah, both. So usually azithromycin again is a good option, but the drug that we very commonly use for toxoplasma is Bactrim DS, and it has worked pretty well for most of our cases. Occasionally, you may need to respond or need to resort to intravitreal injections. And the reason for intravitreal is two. Number one, if you have got a peripapillary toxoplasma, peripapillary toxoplasma needs to be treated aggressively because you want to prevent the eye going into optic atrophy, or a toxoplasma lesion which is impinging upon the macula. These are cases where I also prefer augmenting them with intravitreal clindamycin. Apart from that, one more indication of intravitreal clindamycin is patients who are not or which have got a relative contraindication to Bactrim DS or any of the other antibiotics. And the only important contraindication is in lactating women. All of the other patients, usually all of the medicines that we use have got a penetration into breast milk. So we have had 3 patients who were treated specifically only with clindamycin because of this. The other thing is Bactrim DS, sulfamethoxazole trimethoprim, has got a rare propensity to cause a myelosuppression. So it's important to get your complete blood picture tested for patients who are on Bactrim DS. If you are a patient who is hemodynamically unstable, who has got a coagulopathy, or who has got low platelet counts or a neutropenia, Bactrim DS may be relatively contraindicated. And so again, in these eyes, intravitreal clindamycin may become a good option. Yes, intravitreal clinda for macula threading and for disc involvement. Exactly, yes. Or in patients where Bactrim DS is a contraindication.
You said that in one of your slides that you took a biopsy and it came out to be toxopositive, and then you injected intravitreal clinda. But oral clindamycin also works very well. So what it's that it's fovea threatening, you go for intravitreal clinda, or
I
you can give a trial of
usually
oral clinda also.
Yeah, I usually do not use clindamycin orally that much, though it is uncommon, but clindamycin has got a propensity to cause Clostridium difficile gastroenteritis. And Clostridium difficile then becomes very difficult to treat. So somehow I do not resort to using clindamycin that commonly. Bactrim DS works wonderfully well for all toxoplasma, and we have seen it having nearly 100% resolution. The reason we gave intravitreal was because we were doing it vitreous biopsy, were already inside the eye, and this was a lesion which was very close to the disc. If you remember the case which I had shown, this was a lesion which was peripapillary. So because it was peripapillary, we decided to also give this patient intravitreal clindamycin.
One more very important question I have is that most of these prescriptions we see in the case of uveitis or retinal infections, the set of investigations which are ordered include VDRL but not TPHA. So what is your take on it, and what is the difference, and how can it be, falsely positive in case of just VDRL?
Yeah, so that is what we are now proposing. What we are saying is that your first line of testing should be a treponemal test like TPHA and not a non-treponemal test like VDRL. The problem with non-treponemal tests is that they've got a sensitivity of only 70 to 75, 80% for ocular syphilis. And therefore, you may have patients who may be VDRL negative. When we did a data analysis of our initial 50 patients, we found to our surprise that 11 patients out of 50, which is more than 20% of our patients, were VDRL negative but turned out to be TPHA positive. So what I'm suggesting and what we are propagating for the last few years is that TPHA should be your first test. TPHA is a treponemal test which stays positive. VDRL titers may go up and down. So you use VDRL to monitor the response to treatment. So along with your clinical cure, a four-fold reduction in VDRL titers is a indicator of a clinical cure. But to diagnose syphilis, please get a TPHA done, not a VDRL. Now there's a question, does injection ceftriaxone work as similar as injection penicillin? Yes, it does. But CDC guidelines and most guidelines say that ocular syphilis is treated on the same lines as tertiary syphilis or neurosyphilis, and therefore the treatment of choice is IV crystalline penicillin. I do understand that a lot of time penicillin is not available in private hospital setups, and if you do not have access to penicillin, or if your patient is somehow having a history of anaphylaxis to penicillin, then please go ahead with injection ceftriaxone. That also works very well for ocular syphilis. If you even do not have access to ceftriaxone, then 100 milligrams BD of doxycycline for 28 days. But it takes time to respond. With penicillin and with ceftriaxone, syphilis lesions melt immediately. DUSN, usually you treat your patients with albendazole, but the problem is that this is a question from Dr. Pavan Kumar, but the problem is that most of DUSN that you see are cases where the disease has become quiescent in terms of the infection may not be there, but you are now seeing sequelae. So most of the DUSN that you have seen are eyes which have got pigmentary changes which have already occurred or may have got now a peripheral vasculitis. But albendazole along with systemic steroids works well for DUSN.
Excellent. You can carry on now with the slides.
So I am done predominantly with most of the clinical patterns which I wanted to show to everybody. What if we see a worm in subretinal space? So Dr. Pavan has, so there are multiple small reviews and cases which have been reported of seeing a worm in subretinal space. People have tried doing actually a laser over the worm and that has worked. But these worms in subretinal space also will resolve with your albendazole. So start a patient on albendazole along with steroids to take care of the inflammation. You can do a laser over those worms. People have done. There is a very nice case report by my colleague Dr. Bhavik Panchal and by Dr. Avinash Patangi where they have described doing laser over a subretinal worm. Yeah. So FTA ABS is more sensitive. The problem, Dr. Alpesh, is that FTA ABS is the one which is not commonly available. It is very rarely available. TPHA is the one which is more commonly available. And both of them have got equal sensitivities and specificity. Therefore, because it is easily available, it is cheaper. Therefore, we prescribe TPHA for everyone, not FTA ABS. FTA ABS is not very commonly available in most labs. TPHA is. In 90% of labs, TPHA is available. Therefore, and it's cheap. So that's why we say that get a TPHA done first.
And in the case of the few slides you showed about endogenous endophthalmitis, we see it not very infrequently. So what are the set of investigations you want to order in a case of endogenous endophthalmitis without a history of parental nutrition? In a parental nutrition case, of course, you will suspect Candida, but without a history of that, what are the set of investigations you want to order?
So there are 3 or 4 investigations which I get done for every single patient. I test every single patient who comes to a UVA clinic for syphilis because of its propensity to be a masquerade. So I get a TPHA done for everyone. The second test that I get done for everyone, and that is, I believe, my individual thought process. Not everybody does, and that is I get an HIV tested for everyone. Again, the reason is because you need to, number one, rule out immunosuppression. Number two, you will be probably at one point of time, along with antimicrobial, starting your patient on steroids. And I believe getting an HIV testing done for all patients is mandatory if they've got any retinal infection. So I will get HIV and TPH done for everyone. The third test that I get done for everyone is a complete blood picture. Again, because it will give you a clue to is your patient immunosuppressed in terms of having a neutropenia or a coagulopathy or a coagulation profile abnormality. That again can be a clue to what you may be dealing with. So I get a CBP also because Bactrim DS and some of these drugs may cause myelosuppression. For CMV retinitis, often we treat a patient with valganciclovir, which is a valine ester of ganciclovir and has got equal penetration or bioavailability as intravitreal ganciclovir. But the problem with valganciclovir is that it is also known to cause a myelosuppression. Therefore, before starting valgan, I get them tested for CBP or a complete blood picture. So essentially, every single patient gets tested for HIV, CBP, and TPHA. Coming to the more pertinent question in this case being endogenous endophthalmitis, we also get a blood culture and a urine culture done for them in case they are dealing with a systemic bacteremia or a candidemia. And apart from that, then we go ahead and do a vitreous biopsy.
So yes, I was just coming to it. Not just endogenous endophthalmitis, a patient sitting in a anterior segment setup, a clinician sitting in a anterior segment setup, and of course you treat the patient with the usual drugs you have told and order the investigations, and the patient is worsening. So what is the threshold of referring the patient, or if you have a setup going inside and doing a biopsy, maybe it might be diagnostic or therapeutic. So what is the telltale signs when you think that now the medical management will not work and you have to do a surgical intervention, whether it's a diagnostic biopsy or a therapeutic intervention of the clear of the nidus?
So that depends on two things. Number one, the extent of involvement. Number two, the response. Now, if you see a patient who is having a severe necrosis, your diagnosis is clear. You started your patient. Let's say that you have got a patient whom so these are the clinical clues which we just discussed. Based on that appearance, you have a diagnosis which is clear. Like let's say that you see a patient with HIV positive, has got a CMV retinitis. You inject the patient with intravitreal ganciclovir. The initial dose is usually 2 injections for 3 weeks of an induction followed by maintenance. But within a week, you start seeing a response to treatment. Now, if you see a response to treatment, you know what you're dealing with and you are fine. However, if your patient is not responding to what you are treating with, that is an indicator for you to probably now think of intervening in terms of getting a biopsy done. That is number one, not responding to treatment. Number two, patient worsening in spite of treatment. That again is a clue to the fact that you need to intervene. The third is you do not know what you are dealing with. So let's say that you have done your investigation, they are inconclusive. The disease is not falling into any of the clinical patterns which we have just discussed, and we do not know what the disease may be. Then those are the situations where you probably will go ahead and do a vitreous biopsy. So my indications are number one, when you don't know what you're dealing with, which can happen. Obviously, these infections are confounders. Number two, when your patient is not responding to treatment. Or number three, when the patient is worsening in spite of treatment. So I hope that answers the question, Dr. Vishal. There's another question in the chat box, which is what if clinically pattern looks like TB, but investigations are normal? Then also do you start ATT? Yes.
So when do you start ATT? You refer them to a physician, you start it yourself, or you start it empirically in every cases of suspected TB infection?
No. So I don't start TB ATT in every empirical case, but like I said, I showed those patterns. A serpiginous-like choroiditis is very characteristic of ocular tuberculosis. Even if your MON2 is negative, even if your CECT chest is normal, a serpiginous-like choroiditis is a pattern which is very characteristic. So if I see a serpiginous-like choroiditis, I'll start my patient on ATT. If I see a subvascular pigmentation, and this was a paper which we had published, me, Dr. Soumya Basu, Rishikesh Kaza, and Dr. Vinash, where we have described the clinical patterns of TB vasculitis. So if I see a subvascular pigmentation, again, I will start the patient on ATT along with steroids. And we have just published our data where your patient may be TB immune test negative, but will still have features suggestive of ocular tuberculosis. But the two patterns where I do start ATT in spite of the patient being negative for MON2 are predominantly a serpiginous-like choroiditis or a TB vasculitis with a subvascular pigmentation. Also, history becomes important. So if you see a patient who gives a history of exposure to tuberculosis at one point of time or the other, that also becomes a very important clue. So history of exposure to TB at one point of time or the other, clinical patterns suggestive of TB are
But I think
cases.
clinical pattern is more important because the exposure part is, you more mainly ubiquitous in areas
Exactly.
of India, endemic.
Yeah,
So,
absolutely. So India is an endemic country for TB.
yes.
So for me, the clinical pattern takes precedence. The other question was, do you start ATT? Luckily, in LVPI, we have our own physician, so we start our patient on ATT. What we also need to remember is there is a problem with ATT that is happening right now. In terms of the fact that government of India has changed the guidelines of ATT treatment, where what they have started doing is that we now offer fixed dose combinations to all our patients of tuberculosis. So in the DOT center, they are given ethambutol for 6 months. Earlier, they were given ethambutol. If you remember what we had read, we used to read HRZD for 2 months and then HR for the next 4 months.
Yes.
But now it is HRZD and HRE. So now our patients are getting ethambutol for 6 months. If they go at a DOT center, that's number one. Number two, they are getting it in a fixed dose combination. So whether your weight is 10 kgs or your weight is 25 kgs, you will still get the same amount of ethambutol for 6 months.
You're seeing a lot of ethambutol toxicity these days.
And that is why, exactly, that is precisely why the number of ethambutol toxicity cases have shot through the roof because of the changes in the RNTCP guidelines, which came in 2017. So from 2017, if your weight is 0 to 25, you get same dose of ethambutol. For 25 to 50, 50 to 65, and above 65. So anybody who is 25, 26 kgs is also getting same amount of ethambutol as compared to anybody who's 50 kgs. So you can tell your patient that you only need 2 months, and you can discuss with your pulmonologist, and they have got the alternate regimen available. It's not just that it's the only problem is that's not through the DOT center.
Yes.
But
for it.
yeah, so you can discuss with your pulmonologist and give them HRZD and HR. Not HRZD, HRE. That is a decision which a clinician can make. Over here in LVPI, we have our physician. So we start our patient's treatment ourselves. But for people outside, it is important to have a discussion with your pulmonologist or your respiratory disease physician and discuss with them and explain this is what you're dealing with. And most of the times for physicians, it's difficult for them to understand anything beyond pulmonary TB. But as clinicians, as ophthalmologists, as their treating partners, we can explain to them that we are dealing with extrapulmonary TB and this needs to be treated that way. The question by Dr. Pawan Kumar is, when should we take taps in ARN? I do not usually take taps unless it's absolutely needed. And like I just answered Dr. Vishal's question, when you see a patient with acute retinal necrosis, our usual line of treatment is to start them with not intravitreal, but oral valacyclovir. Valacyclovir 2 grams 3 times a day for 14 days as an induction course, and subsequently 1 gram TID.
But the caveat is very expensive, right?
It is so. The generic version from Mankind and Cipla costs around 500 rupees a day.
Okay.
So if they buy it in bulk from a wholesale retailer, I know this is what we tell our patients. It usually costs around 500 to 600 rupees a day. But there is no other option. Otherwise, you have to admit them and treat them with IV acyclovir. But for that requires hospital admission.
Point taken.
So oral valacyclovir has got very good bioavailability. So I don't take, so Dr. Pawan, like said, I discussed with Dr. Vishal also. I usually initially do not take taps. My only indication of taking tap is if my patient is not responding. Okay, Dr. Alpesh said valacyclovir 2 gram, not BID, 2 gram TID for 2 weeks, 14 days, and then you shift to 1 gram TID. Okay, Amanda has a question. Toxo first episode, no old scar versus viral in immunosuppressed, like the case you shared. Any clinical clue to differentiate or only through imaging? Clinical clues are viral retinitis usually will be not unifocal, can be multifocal, number one. Number two is the fact that viral retinitis usually will have associated hemorrhages. You do not see hemorrhages that common in toxoplasma. Number three will be the fact that an OCT will help you in differentiating. So clinical examination plus an OCT is the answer to Dr. Amanda's question. Do you add any drug like pyridoxine to counter ethambutol toxicity? I do not usually the treatment pyridoxine is given by most of the physicians apart from the TB regimen. But the important point is to ensure that you give that only for 2 months. That's number one. Number two, it becomes important for us to get the renal function RFT done for patients who are started on ATT, because ethambutol has got a renal excretion. So any patient who has got compromised renal functions is at a higher likelihood to develop ethambutol toxicity. So get an RFT done usually. So means is valacyclovir 2 gram tablet available or 1 gram 2 tablets? 1 gram 2 tablets are also available. 500 mg tablets are also available. So if it is 502 grams TID means 5. If it's 500 mg, then 4 tablets in morning, 4 in afternoon, 4 in night. If it's a 1 gram tablet, then 2 in the morning, 2 in evening, 2 in night. Mathematically, you have to ensure that your patient gets 2 grams 3 times a day.
Okay, Mudit, you can carry on with the questions you have
All
prepared.
right. So I believe so. We have discussed most of the infection patterns, and I will request everybody to please be cognizant. The beauty of retinal infections is the fact that you can identify most of them just by their clinical appearance. Dr. Namrata has asked clinical pattern in batches. Batches usually does not follow any specific pattern. But if you see a patient who has got areas of retinitis, which you sometimes can heal without pigmentation, that is number one. Retinitis plus occlusive vasculitis, number two. A very significant hypopion, or what we call as a mobile hypopion, number three in AC, are clues to the fact that you are dealing with probably a Behçet's. So it becomes important for us, and that's why history taking becomes such an important thing. So you ask your patient of history, is there a history of an oral or genital ulceration? If your patient says yes, that may probably make your mind start kicking in directions of Behçet's. You see a mobile hypopion, clue to Behçet's. You see retinitis, and you see occlusive vasculitis, again possible clues to Behçet's, and then you can tailor your investigations accordingly. So as clinicians, it's our duty to not just randomly order for any or every specific test that we know of. Our investigations have to be tailored based on our clinical evaluation. So targeted investigations are always a sign of a good clinician as compared to somebody who just orders every single test. All right. So now that we have gone through all of this, I would like to bring two questions to all of you. I will show you two diseases and I want you to identify the disease that we are dealing with. Whoever types in the diagnosis first in the chat box, according to Dr. Vishal,
He
will
wins
be
the grand prize, or she wins the grand prize.
he or she. And you can take down my address and you can share the prize with me if you want, if you feel that I have shown you good cases which
Your wardrobe is already full of prizes. You don't need any more.
all jokes apart. So let me come to the cases which I wanted to discuss with you. I'll show you the history. So this is the first case. If you can see on the screen, this is a patient diagnosed as intermediate uveitis, was given IV methylprednisolone initially, followed by immunosuppression in form of azathioprine, followed by oral steroids. The patient did not improve. And if you can now tell me, based on what all we have discussed, what is the probable diagnosis that we are discussing? Okay, Dr. Darsha Parihar has written same retinitis. Manisha Singh. So can I tell the answer and the
10
winner?
seconds. Give them 10 seconds. Yeah.
The 10 seconds are up.
Is this the implant, Ozudex implant also in place?
Yes,
Or
yes, there is an Ozudex implant also. If we already have an answer, Manisha is the one who answered first, followed by Ronak Punia, who's the second one. The answer, Manisha and Ronak are right. This is a patient who has syphilis. So now let me show you what happened. So this was a patient who was initially thought of as intermediate uveitis, was given IVMP. Patient vision at the time of presentation was 6/12, which means 20/40 in the right eye and 20/40 in the left eye. Patient did not improve, was given IV methylprednisolone, did not improve, was started on immunosuppression, did not improve, and then in desperation, the treating physician gave them Ozudex. The patient still did not improve. Then the patient was referred to us. The moment we saw this patient, we saw these small multiple yellow lesions, and I am really proud of Ronak and Manisha for having picked up these small lesions, these miliary lesions, the ones which you see in the right eye, and these multiple ones which you see in the left eye. The moment we saw this, we thought, are we dealing with syphilis? We got the patient tested for TPHA. This patient turned out to be positive for syphilis. also turned out to be positive for HIV. This is a kid who was a recreational drug abuser.
Okay.
So just based on these multiple small miliary lesions, the moment we saw this, we had our index of suspicion running towards syphilis. We got him tested, started him on penicillin. The brilliant part is that he came to us with a visual acuity of counting fingers close to face in both his eyes. His final visual acuity today is 20/40, 20/50. So syphilis is a good disease to treat. It's just not a good disease to have. But it's a good disease to treat because it responds miraculously to penicillin.
And
And
what
yes,
was the need of giving deposteroids just to, curb the inflammation
no, we did not give it. This was given by the treating physician.
elsewhere? Okay.
This was not given by us. This patient received IVMP, immunosuppression, systemic steroids, and when it did not improve, then the treating physician also gave Ozudex in both eyes in the hope that the inflammation needs to be controlled. And that is why I made this point. Depot steroids are an absolute no in any case of retinal infection. We treated this patient with penicillin, and then we had to keep this patient on 1 month of cover of doxycycline just because this patient had an active implant also in the eye.
Excellent. And congratulations, Manisha and Ronak. And I think Manisha typed in first. Manisha, I think, where are you from? Can you just speak? Hello, Manisha, are you there?
Manisha, if you can speak for us or if you can type, where are you from?
Okay, we'll contact Manisha.
Army
Army
Hospital
Hospital.
Research and
Okay.
Referral. All right. So
Congratulations.
thank you
Excellent.
for joining us and congratulations. Brilliant answer by both you as well as Ronak. But
You have
Ronak,
a second question also? Yes.
yeah, I have got one more question. So this was the first scenario. Moving on to the second disease. This is a patient who came to us with a decrease in vision for last 1 month, was also under treatment elsewhere and has got this triangular area of retinitis in the periphery, and based on that diagnosis.
Lot of responses.
So, okay.
AR and
Yeah.
AR.
Sahil Jain. Okay, so can I now give the answer?
Yes, you can.
Okay, so the winner is Sahil Jain. Sahil Jain has written Toxo. Ashika Madhuri, Pavan Kumar, Siddhi, Ronak, Pavan, Madhuri, Yashvir. Okay, Purvi Gandhi also has written. So she's the second person. Mosmi Banerjee, again atypical Toxo. Namrata Gupta Toxo, Manisha Yaren. So Sahil Jain. Sahil Jain is the one who answered first. Congratulations, Sahil. Good observation. If you remember what I told you, lesion at the edge of a scar. So this patient, again, you have been able to pick up this sign. This patient actually was being treated like ARN viral retinitis before the patient presented to us. Had been given intravitreal ganciclovir 1 injection and had also been given oral valaciclovir for 10 days before the patient came to us. But what happened was that they did not look at this. This is what we had discussed. A scar adjacent to the lesion. You see this scar and you see an area of retinitis adjacent to the scar. This was an atypical toxo. We started this patient on Bactrim DS. Look at what's happening. The lesion's margins have started becoming more well defined. The lesion has responded. 1 month down the line, see this. The entire lesion goes away completely. So Sahil is the winner for the second question, and the answer was toxo. He was, I believe, I hope he was able to pick up the scar and the ARN lesion. So remember, acute retinal necrosis is a morphological description. The most common causes for ARN are viral. Toxo also is rarely known to cause a peripheral ARN-like appearance. So you see over here a triangular retinitis, but what you also need to see clinically is this scar adjacent to the lesion. And this in itself helped us make a diagnosis. We saw the scar, we realized we are dealing with toxo. We started this patient on Bactrim DS. Of course, in hindsight, we also were lucky because we knew that this patient has been given valaciclovir and is not responding. So one very important clinical clue in infections is also a response or non-response to your treatment. It's important for us as clinicians to follow up these patients clinically. You start a patient on treatment. I usually end up seeing them again after 1 week to see how they're responding to treatment. So remember, when you see a patient who's not responding to treatment, what does it tell you? It tells you, number one, either your diagnosis is wrong or your treatment is inadequate, and you need to go back to the drawing board and realize what you are dealing with. So Sahil is the winner of the second question.
Congratulations,
Here are
Sahil.
you-
I guess you are from SMS Jaipur,
Yes, sir.
and
Yes.
I hope that you saw the scar and it was just not a random diagnosis.
No, sir. The adjacent. Yes, sir.
Okay, congratulations. Nice observation.
Oh. So those are the two cases and two quiz questions from my end, Dr. Vishal.
Excellent. So, just to conclude, this has been a wonderful Kaksha on retinal infections. Thank you, Dr. Tyagi. And it was a very well explained in a very comprehensive yet crisp presentation, a wealth of information. And I, urge all the residents and the, participants who have logged in to go to the YouTube channel to just, have a look at the class again to grasp so much, which you might have missed, some things in a 1 hour class. So thank you all the residents, the ROS executive, respected teachers, and Dr. Mudit for the excellent teaching. We look forward to the next class in the coming weeks, and keep giving your feedback and suggestions for the Kaksha experience to improve. And do subscribe to our official Rajasthan Ophthalmic Society channel on YouTube. All the previous Kakshas, including this one, are uploaded there. You can go through them. And good night from Team ROS. Thank you, Mudit. Thank you so much.
Thank you so much, sir, for having me, and thanks to everybody at Team ROS. It was a pleasure spending this evening with all of you. Thank you so much.
Bye. Take care.